Hello, everyone. This is Faisal Latif. Thank you very much again for the invitation from Gulf Interventional Society. I'm here on behalf of SCAI, and I'm going to talk about maintaining morale and preventing burnout in the cath lab. Here are my disclosures. So essentially, what is morale and what is burnout? Good morale is confidence, enthusiasm, discipline. You want to come to work. You enjoy your work. You're happy about it. And on the other hand, the low morale or burnout is when you're emotionally exhausted. You feel depersonalized. You don't care about yourself as much, and you feel a sense of reduced accomplishment. That's heading towards burnout. Why is burnout on rise in the cath labs? Well, there are many factors for it. Not feeling valued by the organization or the hospital you work for. Increasingly being measured. I gave a previous talk about the NCDR. We are being measured. How many of my patients are having bleeding? How many of them are having acute kidney injury? So on and so forth. That's stressful. There are complex regulatory environments. I've got to do 50 PCIs in a year or 100 PCIs in a year to continue to have credentials. High staff turnover is a big role. Unpredictable hours and is a problem. One day I'm working till 5 o'clock, another day we may be working till 11 o'clock. And then call comes in. The call, basically the frequency of call, how busy the call is, how many times you have to drive back and forth between home and hospital. All of those factors play a role. Physicians are the anchors of the team. So this survey was done a few years ago, and it showed that among cardiologists, about 43% of the physicians felt burned out. And this burning out is based on several questions. Do you feel interested in doing certain activities? Do you take a vacation? Do you feel depressed? So on and so forth. And 43% of physicians, cardiology physicians, were affected. It increases with age, actually, and it was shown to be higher rates in female physicians. So what do we know from research in this area? So in this meta-analysis of studies of interventions to prevent and reduce physician burnout, there were certain measures taken to improve burnout, and there were 15 randomized controlled trials, including 700 plus physicians. And there were 37 cohort studies in this meta-analysis, including 2,914 physicians. Overall burnout after certain interventions decreased from 54% to 44%. That was an important achievement in this particular initiative. An individual focus and structural or organizational strategies resulted in clinically meaningful reductions. I personally have seen that more and more hospitals in the US are trying to implement various measures to help their healthcare workers in general and physicians in particular, to try to help them come up with strategies to reduce the stress, reduce burnout, and improve their well-being. It was seen in a nursing survey then that about 33% of nurses felt that there is inadequate staffing levels at the place of their work, and 2 in 5 units were short-staffed, and 54% reported excessive workload. So half of the nurses say that they spend an insufficient amount of time with the patients. If you're taking care of the patient, but you have so many patients that you cannot spend enough time with the patients, that's also not satisfying, and that basically leads to decreased morale and burnout. How do we improve that? What are the strategies to build morale? So important things are encourage team innovation. Have a team. You work with certain people more than other people. So that's your team. Have a unified mission. If you're in the cath lab, then have a unified mission that, we will try to be more efficient, try to get through the day quicker, so on and so forth. Fix problems, don't cover them. If there are problems happening, that sometimes, there are staff that are staff or between staff and staff physician, there may be things that are not going so well emotionally. Try to fix them instead of covering them up. And that's where the job of the cath lab director becomes very important. Use some non-cash rewards, maybe celebrate birthdays of the staff, or have some activity which is non-work activity. Plan some social activities, maybe go out to dinner, go out and have a picnic on a weekend. And also, we have to be very careful about use of email. Email is a permanent record. It never goes away. It always lives in the cyberspace. So there are certain things that you should not use email for. A face-to-face talk might be much more effective, while an email can be much more inflammatory and therefore should be avoided in conflict situations. Also, it is important to promote the camaraderie and friendship among the team. The attending physician, the cardiologist, basically has a responsibility to recognize the team with a certain gesture or activity. One way to recognize the team is that at the end of each case, you can say thank you, and say thank you to each member of the team individually. Thank you, Muhammad. Thank you, Michael. Thank you, John. And this may happen naturally over time. They feel valued. This is not a big word, but once the case finishes, it is helpful that the team leader, that the cardiologist basically recognizes the team. Then there are some other things that can be done, like an end-of-year gathering, some holiday lunches, maybe tickets to go watch a sports event or a concert. Posting thank you notes from patients. When that is very satisfying to the cardiologists, the physicians, and also to the cath lab staff. If a patient was very sick but now has gotten better and sends a thank you note to the cardiologist, share it with your staff, because your staff will also appreciate and get a sense of gratification out of that. Eating lunch in the break room is a great way to connect with the team and talk about non-work activities instead of going and having lunch, separately. What are some common scenarios that lead to burnout and low morale? So, frequently asking or mandating staff to stay late and then complete all the add-on cases, stay late in the evenings. The problem is the unpredictability of your schedule. When you come in the morning, you were hoping to go home by 5:30. But what happens is there were 2 add-ons and now you're going home at 7:30. That affects you mentally. So there could be, that affects you personally, and that affects you in terms of your family. There could be childcare involved. Somebody's taking care of your kids. You have to go pick up your kids. Your social life is involved. You may be going out to a dinner or, going swimming, and you cannot do that anymore. You may be going to the gym to do some exercise and you're unable to do it. All of those things play a negative role in the well-being of healthcare workers in general, and also physicians and cardiologists and interventional cardiologists in particular. So what are the solutions? The solution is planning, scheduling. Basically, track the frequency of keeping staff late. What's going on? Maybe there are downtimes in the middle of the day that you can make yourself more efficient. Like, for example, I once heard that a very elegant, top-notch hospital in the United States, they have a policy that they have a very busy cath lab, but they finish their work by 5 o'clock. And they have a very efficient system. So basically, their turnover times are lower, their downtimes are lower. They do a ton of work. They do a lot of complex cases. They do TAVRs, but they are able to get their staff out at a very reasonable and a consistent time. That helps a lot. Scheduling a backup team. So if there is one call team, but there may be a backup team, because if a call team is there for 8 hours in a row, maybe they need some rest and a backup team can come in and help out with the next STEMI. Work with physicians to prioritize cases that, there are some patients who may be able to wait another day or two for their procedure, while there are some patients who really need to go early. So prioritize cases. Don't wait for your non-STEMI, high risk, somebody whose troponin is 30, to do it at 8 p.m. Instead, try to do them earlier so that you are not left with the most important case of the day at the end of the day. You want to prioritize those patients and maybe do your some other case later in the day, or do them the next day. And then look to the improvement in daytime efficiency to have more flexibility for urgent add-ons. I think is the key is a key solution to this problem. Then having a predictable schedule and a predictable type of case, like, there could be certain staff in the cath lab who do chronic total occlusion, certain staff who do critical limb ischemia, because when you are familiar with the type of cases you are doing, first, you're not hoping to get out of the case in 40 minutes. Your case may be 3 hours long, but you are prepared for it. And then you are more familiar with the setup, and you know where the equipment is. And how to help the cardiologist or doing the case. That would be much more effective and less stressful for the physician as well as the staff. In servicing staff, so the equipment that you use less in the lab, that the in servicing them on a regular basis, like for example, if you use Impella in the lab, but you don't use it for 3 months, you tend to forget how to set it up. So maybe having regular in-services for that kind of stuff, rotablator, that would be helpful. Organizing the equipment, like if you're doing complex cases, then all the equipment for complex cases maybe can be in one cart that you can move from one cath lab to the other when a case comes up in that particular room. Also, another thing is to do regular drills on complications. Like, for example, if a patient has a coronary perforation, do just a practice drill that, okay, a complication has happened. Now, what are we going to do? Okay, the staff says we need to get a covered stent. Where are the covered stents? We need to get a coil. Where are the coils? So on and so forth. So those things are helpful and decrease the stress when such a situation actually arises. Dealing with errors, not walking away, is important. Bad outcomes happen. We are in the business where patients' life is at stake. So sometimes, not all the time, we are going to have the best outcome for the patients. Everybody gets depressed when you lose a patient in the cath lab. So we are all humans. The important thing is the team leader, the cardiologist at the end of a case that did not go so well, there was a complication or a mortality, talk to your team. Have, kind of do that is good for yourself, it's good for your team to try to come out of that difficult situation. These are heart-wrenching cases, and therefore talking it out actually helps. If a death happens, maybe a moment of silence for deaths, maybe a moment of prayer for the person who died would be helpful to get over that difficult situation, that sorrowful situation. Now, if complications happen, it is important to not walk away from them completely. It is important to review the case. It is important to have a peer review process so that the complications are reviewed, and solutions are sought to decrease the risk of complications. If there is something that can be improved, then those measures should be implemented. So finally, my conclusions are burnout is common, especially we have lived through very difficult years of COVID. Hopefully we are getting over it. But the burnout is common among physicians as well as the staff and should be acknowledged. Every hospital administration should take measures to improve the morale of their staff, and also the strategies to combat burnout and low morale exist out there. Use them to your advantage and have a healthy cath lab environment. Thank you very much for your attention.